Good Friday morning, everyone. Dr. David Wild, Vice President, Performance Improvement, sitting in again for Chief Medical Officer Dr. Steve Stites. We are coming to you from the Dolph Simons Jr. Family Broadcast Studio. Today, Amanda Cackler, Director of Infection Prevention and Control, is back to help us answer your questions. But first, Dr. Nathan Bahr, Infectious Disease Specialist, is here in for Dr. Hawkinson. And he has our numbers. How are we doing this morning, Nate?
You know, things remain pretty stable overall. So we currently this morning, have 60 patients with active infection. That's from 58 yesterday, so that's slightly up from yesterday, but pretty in line with what we've been seeing. We have an additional 65 patients that are considered no longer active infection, but still obviously needing hospital care and some very sick. That's from 60. So our total is 125 actually from 118, which is up a little bit. But you know, when we say things are stable, obviously we know that comes with peaks and valleys and it's not a straight line. And so, you know, today we're a little higher, yesterday we were a little lower, and so we remain pretty stable. The ICU patients amongst the active, we have 20 right now, and that's from 19 yesterday, very similar, and 11 patients on the ventilator from 10. So all that's fairly similar, fairly stable, still a lot of sick people, and still a lot of disease. In Hays, they are at 17 inpatients today. They were at 18 yesterday. Unfortunately, they had 2 deaths again today, or in the last 24 hours. So, you know, people are still getting really sick out there here in our facilities and in Hays and in the community as well. And so, still a lot of COVID, and still really need to keep taking all this quite seriously with our prevention measures.
You know, Dr. Stites and I talk weekly with the other chief medical officers across the city here in the Kansas City Metro, and we had that conversation yesterday, and everyone is sort of in the same boat. Stable, at a plateau, up and down a little from day to day, but much better than we were as far as hospital capacity and census, say, in late November or early December. So I do think we have established ourselves a new baseline, sort of landed at this new plateau, which in itself is a good thing. It means that we're not increasing in new infections or increasing in hospital census, but that plateau is higher than the previous plateau. Yes. So that in itself is not a good thing, but better than some of the other options. So in general, I think the bottom line that you mentioned of there's still a lot of disease out there, and it still is real and severe in many patients, and there's an impact to the hospital and healthcare delivery system across our community. Those things remain true. Good reminder that all of the things we've been talking about for months now still remain very, very important as you think about how you keep yourself and your family safe. Let's go to the media questions for the day. Are there any reporter questions on the line?
I have one. It's for Channel 9, and Donna Pittman is asking, we are seeing counties fall short when it comes to vaccines. And she said, I think you may have covered this before, but would you please respond again? What if you get your shot, but then the supply is short for your booster?
So the timing first for booster or second doses was really established by the phase 3 trials for each of the vaccine candidates. And so the Pfizer vaccine candidate has a 3-week period between first dose and second dose, and the Moderna has a 4-week period between first dose and second dose. But there was a range in each of those trials that between first dose and second dose that checked efficacy and impact of the vaccine. And so from those ranges, we know that earlier actually might be a bit of a problem. So too much earlier than the 3-week mark or the 4-week mark may have a negative impact, but being later than the identified time frame is not bad and actually may lead to more immunity. So we heard that from very clearly from Dr. Polland when he was here last week, that for nearly every, maybe one exception, vaccine candidate that we have for all diseases that has a first dose and a second dose, the T-cell immunity and the antibody response is actually greater if you have a bigger gap between first dose and second dose. So You may have seen or heard even that the CDC said yesterday that you can wait up to 6 weeks between first dose and second dose if you need to, clinically. That is not a bad thing. Of course, we understand everyone's desire to reach the highest level of immunity they can as soon as they can. And so that is the balance. How quickly can we get there, combined with the fact that we need the doses? So I hope that provides sort of the context to answer the question that if you don't get it right at week 3 or week 4, depending on your dose, that's not a bad thing.
Yeah, I think, yeah, that's the main point, that it is going to be all right if that's what happens. But of course, we all want that second dose as soon as possible, just to get us up to that highest level of immunity as soon as possible. And yeah, the communication from CDC yesterday, I think, really helpful on this matter. And I think it's very clear. So anybody that has questions, CDC is rapidly communicating in these areas. And I just got to say, as an infectious disease doctor, the new CDC director, Rochelle Walensky, is she's phenomenal. She's a superstar. She's been an incredibly impressive infectious disease physician researcher for a long time, and I'm very excited for her leadership.
Any other media questions on the line today?
I do have just one more, and it just is speaking to the effectiveness of Moderna and Pfizer, and they're just saying that on some websites, and they mentioned Truman as one, and I did call Truman and ask him about this, but they said that they talk about Moderna and how effective it is, but Pfizer doesn't have the same information. And so she's wondering, is there been a change in the effectiveness of the vaccines?
No, they're both very, very good in effectiveness, and extremely confident in both of them. So I'm not sure why there would be a difference on any websites, but no, there's been no change in that, and we remain extremely confident in both vaccines in terms of efficacy.
And the last question in that same question is, how long before we know if it prevents transmission, if the vaccines prevent transmission?
Yeah, I think that'll depend on some of these studies. The initial large studies did not include, for these 2 vaccines, swab data from people after they were vaccinated, and that would have been the best way to do it. But of course, rolling out a massive study incredibly quickly, the main things were to make sure it was safe and efficacious, and so that was the way it was done. There are some efforts out there to get this sort of data, but that's not going to be quick. And but I think there is, we don't know how effective it will be in preventing transmission. I think the likelihood that it does to some degree is pretty good. I think it would be very unlikely that it does not prevent any transmission. But to what degree that's helpful, we don't know. And that's why even if you're vaccinated, these, keeping your distance, keeping masks on, those are so important, because we just don't have a good understanding of that yet.
All right, that's it for now.
Okay, well, while we get ready to go through the questions that we haven't been able to get to from you all across the course of the week, there were 2 specific topics that come up frequently. One has been, what about these new variants or mutations? And the second has been, what's happening in your hospital with those being vaccinated, and is it preventing them from getting ill, and is that having an impact on the healthcare workers, or the number of healthcare workers who have been ill? So a couple of slides to address both of those things, and then we'll jump into individual and specific questions from the week. So this is really just a point of reference. There's a lot of information on this slide, way more than even I think Dr. Bahr would want to talk about. So
No, I'm an infectious disease doctor. I love this stuff.
This is really a point of reference to say there are 3 primary variants of concern that are receiving a lot of attention right now. They have different names. In fact, they even have some alternate names. They can be called by a number of different things. And the table just summarizes here that they all have a number of different mutations. Some are similar from variant to variant, some are different. But the things that I wanted to highlight are the 2 values that are sort of highlighted here in red. So for the B.1.1.7, that's the UK variant that you've heard so much about. In the transmissibility change row, you see that this variant has somewhere around a 40% or more increase in transmissibility. That doesn't mean that it causes more severe disease or it is more deadly. It just means that it spreads to more people easier compared to some of the other strains that we have seen. And we're going to talk about what that means in a minute in a graphic. I hope that makes that very clear. Secondly, the B.1.351 variant, which is the South African variant that you've heard about, on the immune escape. This is the question about, will there be an impact to these mutations on the efficacy of the vaccines that we currently have available? And so here, the mutations for the spike protein, that sort of getting into the science, are enough that there's some concern that it's probable, maybe even likely, that there will be a decrease in efficacy of the existing vaccine candidates. But remember, that doesn't mean they don't work. This is not an all or nothing, light switch on, light switch off thing. It just might mean that instead of saying 94 or 95% efficacy, that we say 80 or 85%, which is still very, very important in the big picture. So anything you want to add to tee up the rest of the conversation?
Yeah, I think that's a great way to put it. I mean, the early papers that are out on this 351 strain are essentially showing slightly decreased antibodies, but are pretty clear in the paper. It's not clear how much that actually is going to affect a person clinically. And so they're not massive drops in antibodies, which is, I think, the most important part. We're still going to see the vaccines able to cover them. It's just, yeah, maybe it's not quite as good for that particular variant compared to some of the others, but I think the likelihood is that they're still going to be quite good. And then the transmissibility piece, I think, is quite important. You have more to say about that, so maybe I'll just...
Okay. So the specifics on these slides are going to be a little bit hard to see for some of you. The wording isn't as important. I'll talk through. This is a representative example. So this is assuming that a community, any community here in our area, has a consistent, right now, 1,000 cases per month, new cases per month. And so that's represented by the top sort of set of darker brown people. That's the number of infections that are happening on a regular basis in a month, and they're stable. So this is saying that we're right around one infected person infecting one other. We'll talk about that being replication rate, and it's stable. If transmissibility increases 50%, meaning the replication rate is 1.5, or every one infected person is now infecting 1.5 others on average, there are now 10,000 new cases instead of 1,000 in a month. That's transmissibility. I'm not talking about outcomes now, we're just talking about how disease spreads. So that's the impact of a 40% or more increase in transmissibility for a variant. That's why we're talking so much about this. So that's how many people will be infected. And remember, we've talked a lot about the more people there are that are infected, the more people there are in the hospital, the more people that will die. And that's not because the rate of hospitalization increases or the rate of death increases. It's simply the percentage, the same percentage of a larger number of infected people is a larger number of people in the hospital or a larger number of people dying. So the next slide really makes that case around deaths. So this is the same look, right? 1,000 active infections or 1,000 new infections in the population per month. If one, each of the colored, the solid colored people here in the first sort of column equals a death. So if the mortality rate is 0.8%, which is fairly reasonable for an estimate of the mortality rate. The percentage of those that get COVID that don't survive is about 0.8%. In a month, that would equal about 130, 129 deaths, something like that. That's the sort of the top row that you see here. So let's assume first that we're not talking about an increase in transmissibility, but we say that the disease becomes more deadly. So now instead of 0.8, percent, let's just say it's 1 or 1.2. So a change in the mortality rate, the severity, the death rate of those infected. We actually only increased to maybe 180 deaths, not a very significant increase, give or take on those numbers. I'm using round numbers. That's the sort of second row here. But the bottom row where you see all of these new deaths, 970 some odd deaths represented here, is what happens when transmissibility increases. If the mortality rate stays the same at 0.8%, but the transmissibility increases, so many more people are infected, what we just saw in the last slide, that the death rate goes up by more, I'm sorry, not the death rate, the number of deaths, the actual number of deaths goes up by more than 600%. 978 here in this picture. That's the impact on deaths of higher transmissibility. That's why this is so important. So the disease in the case of these variants is not more deadly.
Right.
The same percentage is dying, but more people are transmitting the disease to others, which leads to a very rapid increase in the number of infections and therefore a very rapid increase in the number of patients hospitalized and the number of patients that die. So this is the concern of a variant that has an increased transmissibility. It's the reason we talk so much about the things that you need to continue to do, even when there's a Chiefs playoff game this weekend, to keep yourself safe, because I can nearly guarantee that this variant that has an increased transmissibility is here in our community. While we've not found it in isolates that have been sequenced in the state of Kansas yet, as we talked about yesterday, it's more than 20 states have, and those states surround us. So a very, very real concern here as we try to really, really, really re-emphasize over and over that the pillars of infection prevention and control that we've spoken so much about and really tried to hammer home are still important now, maybe more important than they've ever been as we see a strain that might have a bigger impact. So anything you want to add?
Yeah, I think I would just say that, that's an excellent picture of sort of large scale what that means, and obviously hugely important for our communities, for our country, the entire population. For an individual person, what does this mean? It means that, these, as you said, the pillars of infection control remain so important, and that's because anytime, we're too close without a mask, that risk is now higher. So the risk of us getting infected personally, if we have a large group of people together, or us passing it to somebody else, becomes higher. We now have increased risk of that personally as well. So it is very important population-wise, but this is a personal risk for everyone as well, for you and your loved ones. So keep on the mask, keep on the distance, outdoors, all those things remain extremely important.
And I imagine the infection preventionist in our group, Amanda in Studio B, might have things to say about that. We've not seen her smiling face very often this morning. But Amanda, anything along those lines related to the importance of infection prevention in this context you want to add?
I think you hit it already, because you're stressing the importance of or the impact of the mutation, but it really doesn't change anything. Like, it stresses the importance of continuing what we've been doing for almost a year now.
Great, thanks. All right, so on briefly to the topic of what is happening with our employees. So we get this question a lot: how many have been vaccinated? How many are out? How many are being tested? And I brought just a couple pictures. I hinted at numbers yesterday for an individual day, but the first slide, stack bar chart here. So the bottom, the blue colors are the number of employees out any given day because they are positive for COVID and on isolation. And remember, we have 13,200 or so, maybe 13,500 healthcare workers or employees here in Kansas City alone. So when you see a number on any given day that looks like 200, is a small percentage of our overall workforce, but still significant. So you can see that blue line had peaked in November and has decreased over time. A little bit of an increase as we came out of the Christmas holidays, and we're actually at one of the lowest levels we've been in many, many months, since October this week, of a number less than 90 out on any given day. The orange bars are the number who were symptomatic and either were tested yesterday and awaiting results, or are out today because they have a test scheduled. And so you can see that number has decreased as well. And it's been just over a month since we started vaccinating, and you can see how that number has decreased over time. I am sure that the vaccination process has helped in this. Now, of course, I need to maybe add a little context or make sure we understand. I'm not saying that the decrease here is solely due to vaccines, because we've seen the number of infections in our community decrease over time as well. But that decrease is maybe 15% or 20%, not the decrease we see here. So there's an additive effect of both of those things. And to reinforce that, the last slide simply shows you the number of the average, 7-day rolling average number of newly positive employees we have on a daily basis. And so you see that number, again, looking at the November to now time frame is 6, now the lowest it's been at any point in that time frame. So we do believe we're seeing the impact of vaccination on our employees, and know that we would anticipate a similar impact as we get more and more of our overall population vaccinated. And to tie this together, right, the population of the overall, the percentage of the overall population that has received one dose of their vaccine as of today is 4.5%. The percentage that has received both doses is less than 1%. We have a long, long way to go in our vaccination journey. So that's what I brought from the perspective of slides today. I know we got lots of questions to get to. Hopefully that addresses some of the more frequent ones that have been coming in. But Jill, let's get started on those community questions.
Great, and we do have some good ones that came in this morning. I'm going to hold them to the end. Let's rock and roll through these. Question number 1. My doctor's office said the COVID-19 vaccines are safe to take as long as I don't have any contradictions. What contradictions would prevent me from getting the vaccine?
So the contraindications for this, essentially it's an allergy to the vaccine ingredients. So it's very specific. There's not many contraindications, and so if you're worried you have some sort of obscure allergic reaction history, you can easily find the ingredients to these vaccines. Yeah, just go on the internet, you'll find it, no problem. But these are pretty rare things, and so thankfully there isn't many contraindications.
Okay, number 2, does COVID-19 cause seizures or epilepsy in patients? Is COVID-19 likely to trigger a seizure if I already have epilepsy?
It can cause seizures. It's definitely something that has been seen. I think, the likelihood in any individual case is always hard to talk about in terms of somebody that already has epilepsy, but in general, if somebody has epilepsy and they get another trigger, it's definitely possible that would contribute to a seizure in that effect. So yeah, COVID definitely can cause seizures. It's not extremely common, but it does happen.
All right, next question. Can cancer patients get the vaccine?
I think the answer to start out there is yes. There may be individual timing concerns around specific therapies that might be part of a treatment plan or surgery or other things that happen for cancer patients. But in general, the answer is, of course, we know that cancer patients at certain points in their treatment cycles have their immune systems suppressed and might be more likely to be infected if they're exposed. And so all of those things lead us to say yes, but of course have a conversation with your oncologist, with your treatment team, to make sure that the timing is right when you are in a position to be able to schedule an appointment.
All right, next question. Question number, let's make sure I'm on the right one.
Question 4.
Yes, question 4. Do hospitals in the area practice the same protocols for COVID-19 and offer the same treatments?
So I'll start, I think, by tossing it to Amanda. I think there are multiple questions here. From the perspective of how do we take care of these patients, not treatments, but how do we manage them in the hospital? Do hospitals follow the same protocols around infection prevention and management of their patients?
We absolutely do, and we've been learning from one another when different situations arise. That's like one of our first things that we do is we ask other local hospitals how they're managing visitors, how are they managing cohorting patients if they need that double occupancy room utilized. But the basic pillars of infection prevention, so wearing universal eye protection and universal masking, good hand hygiene practices, staying home when sick. We've really been doing very, very similar practices, and we constantly are in contact with one another to make sure that we are doing the same thing, and we're seeing really similar outcomes in, as you know, with your CMO calls, getting about the same outcomes as well.
And Dr. Bahr, on the treatment front, treatment protocols, are they similar between institutions?
You know, they're pretty similar. They're not going to be identical, and that's because, you know, the evidence isn't, in most cases, a very cut and dried thing. Especially early on, you know, we had a lot of treatments that were being considered that we weren't really clear how well they worked. In some places, took different approaches than others for those. And of course, individual doctors might do the same. As we've went along, we've gotten more certainty in terms of evidence. And so, you know, we know that, you know, steroids are sort of a very critical part of treatment for COVID-19. We know remdesivir in some cases can be helpful, though probably not to the same degree that steroids are. And you know, we've learned more about treatments that aren't effective as well. And so I think as we've gone along, the protocols in various centers tend to be more similar than they were. But there's still some differences, and that's just because there still is some uncertainty in evidence. I got to tell you, it seems like every day I wake up and find a new study that I need to consider and how this is going to affect our protocol. So it's you know, they're not going to be exactly the same because, wow, there's still so much coming out constantly.
I think on both fronts, Amanda and Dr. Bahr just mentioned how much we have been learning, how rapidly those learnings are coming, how effectively we are sharing from institution to institution what we're learning and how we're operationalizing those learnings. That's been truly, I think, one of the, at least in my career, one of the unique experiences of gathering so many different healthcare delivery systems, which we've always talked, but always also had just a hint of, you know, we do things our own way or we work inside our own group, and now that has really, really changed. And I think that's great for patients. So if there is a silver lining, and I'm sure there are many, although they're hard to see right now, I'd say that's definitely one of them.
All right, next question. Why are type 2 diabetic patients in the first round of vaccinations and type 1 diabetic patients are not? Aren't all diabetics at higher risk if they get COVID-19?
So lots of difficult topics to address here, and I'm going to need some help from my friends too. But let me start with, first of all, as each state has made their own plan of prioritization and distribution of vaccine doses, there have been very stark differences in the strategy and approach. So at the most basic level, there are some approaches that are focusing on preventing morbidity, meaning the occurrence of COVID-19 and its transmission in the community. And there are other strategies that are looking at mortality. Does COVID infection cause death? And you can tailor your tactics, how you distribute vaccine, to address one or both of those concerns, and states have done that. So Missouri has included those who have some chronic diseases, and I think this is the question, type 2 diabetics in Missouri are on the list, where maybe type 1 or not. But on the Kansas side, the focus has been more on mortality, those at a highest risk of dying, and we know that that group is actually not particularly impacted by most comorbidities. While individually there may be a risk of severe disease to you, those with the higher risk of death are those who are elderly, over 65 or 75, those who are obese, those who've had a transplant, and maybe a couple specific types of cancer as we start to get really big sort of picture studies. So that's sort of the context in which to say, I don't know that there's a big distinction in the evidence between type 1 and type 2 diabetics for the morbidity conversation. Yeah. Are you more likely to get severe disease or not? But we know from the mortality side, if the state's approach is focused around mortality, neither type 1 nor type 2 diabetics have a significantly increased risk of death than the general population. So I don't know. Take it and see where you go from there, Nate.
I think you said it pretty well. I mean, yeah, I don't know that there's a big difference in terms of type 1 and type 2 diabetes with respect to severity of disease, things like that. So, I guess I can't speak for why those decisions were made, but obviously, these are folks trying to take in all the evidence and make the best policies they can. But I can't say the reason behind that specific choice.
Next question. Once I have both COVID-19 shots, can I still pass COVID-19 on to someone else and not even know it?
Amanda, you want to start?
Yeah, I think that's what we don't know yet. We think that there's probably some likelihood that you could still carry it. We just don't know. And I think it stresses the importance of, even if you have been vaccinated, how important it is for you to maintain your social distancing, wearing your mask, staying away from folks if you have symptoms of any kind, and because we don't know.
Yeah, I would agree.
Okay, assuming the AstraZeneca and Johnson & Johnson vaccines receive emergency use approval by the FDA, will they protect against the new virus variants?
Dr. Bahr?
Yeah, that's still to be determined, I think. So, first step is we got to get really good efficacy and safety numbers so that we can, know whether, we can move forward with these vaccines. But then it's studies like we're just seeing start to come out now with these vaccines that do have emergency authorization. And so it'll be a bit of time before we know that. I would not be shocked to see, these companies perhaps cooperating with labs that do that type of work in the meantime while they're aggregating their data and things like that to try to understand it better. But I don't think we know the answer to that yet.
My 16-year-old daughter who works in a daycare has been told she's eligible to get the vaccine in phase 2. Should she?
Yes. Sorry,
Yes.
I interrupted you there?
Yes. So yeah, first of all, child care workers, licensed child care workers and teachers are included in phase 2, I think in both Missouri and Kansas. And so if anyone who has that responsibility is contacted or told they're eligible, yes, get the vaccine. It's absolutely something that we would suggest. Separately, the question about 16-year-olds. So the phase 3 trials did include authorization based on data from the phase 3 trials for 16 years of age and older. And we know from conversations with our colleagues at Children's Mercy, for example, that they are vaccinating those that are 16 and older who are phase appropriate, if you will, in phase 2. So the longer answer to yes remains yes.
Yeah.
Okay, and is it safe to fly if I had COVID-19 within the past 3 months? Do I have immunity? Would I make anyone sick?
Amanda, you want to start again?
Yeah, so I think this question really goes back to, is it safe to do anything? And so it's a matter of keeping your individual behaviors is extremely important. So you still should wear a mask. I know Dr. Hawkinson traveled early on and he was promoting eye protection when he was on an airplane. Whenever you're in the airport, maintain as much social distancing as you can. Take with you the hand sanitizer and that sort of thing. If the question really is, because I've had COVID in the past, could I transmit it onto someone else? I think that's another question that we don't know. Because you've had it before, you might have some immunity built up, but could you still be a carrier and transmit it to somebody else? I think there is a likelihood of that. And so it's just a matter of maintaining those good individual infection prevention practices while you're doing it in public. Around folks that aren't traditionally in your bubble.
Yeah, they're within that 3 months of an infection, it's unlikely that you're going to be reinfected, but there have been reports of that. And so, when there's any uncertainty with this, my answer is always wear your mask, keep your distance, do all those things we can do because, there's things we can do without a ton of burden, and they're going to make everybody safer. So, is there a chance? It's even if it's a small one, just do the right stuff. But yeah, I think you can fly. You just got to do it safely.
All right, and the last question that we have on a slide, but I have 2 or 3 more if you're up for it. Should long-haul COVID-19 patients who still have symptoms get the vaccine?
Yeah, I would say yes, and the reason is you can, some of these long haul patients are having symptoms many months out. I mean, as long as we've known about COVID, there are people that had it early on that are still having symptoms to some degree. So what that exactly is can vary person by person. But when you're that far out, the damage that was done is causing the symptoms, right? So it's not active infection anymore causing symptoms. It's the damage that was caused by the infection and the immune response. So that same person that now perhaps has lung damage and has chronic lung symptoms, chronic lung disease. In fact, getting infected again with COVID would be really bad for that person. So yes, get the vaccine because the safety risk is not any worse than it would be for anybody else, but the potential to prevent another infection would be even more impactful for that individual.
Okay, and some on-the-spot questions from the viewers today. Vicki says, one of my doctors told me she is concerned that these vaccines could, in quote marks, turn on an autoimmune disease in some people. Do you have that concern?
Yeah, I've heard similar sorts of concerns out there. I'm not worried about it, quote, turning on a autoimmune type of disease really at all. What I've also heard in concerns is, well, what about possibly people with existing autoimmune diseases? Could this cause them to flare somehow? And, what I'll say is, in these studies, they did not exclude people with autoimmune diseases, okay? So if there was a big signal, we would have seen that in the studies. So to me, that's very encouraging. I have a mom who has lupus. I'm not telling her no. I'm telling her, yes, please get it the second they give it to you. And so I hope that gives y'all a little reassurance. If you've learned to trust me over the last few days, at least, maybe that'll make you feel a little better.
Those are always, I think, the sort of the best answers to that question. What would you do? Well, yes, I would say yes in that circumstance, the same. And Dr. Polland, to sort of revisit his conversations, talked about this a bit when he was here last, in that this specific question is frequent for those who are hesitant to receive the vaccine. Will it cause an autoimmune disease, or will it flare an autoimmune disease? And the reality is, in the overall vaccine literature and all of the evidence for vaccines, we don't really see that problem. Yeah. And so we wouldn't expect it here either, not in large numbers. And we've, I think, to your point, Nathan, we've seen in the evidence from these trials, including for patients who have autoimmune disease, no signal that would suggest that that's a concern. And the numbers are big enough now that we would have if there was a real issue there.
Yeah. I mean, anybody that's got the vaccine knows you're invited to, give data about how you're feeling to CDC so that they can aggregate it. And, they've been very forthcoming with this type of data. We've talked about allergy data. That's where this sort of information is coming from as well. So if there was a concern, I have no doubt CDC would be discussing it because, we want to make sure people understand what the risks are. And thankfully, these are very safe vaccines.
Okay, just a couple more. Sean wants to know, is there any concern about allergies to latex and getting vaccinated? He thinks it's one of the screening questions. He wants to know why.
I don't know why it would be a screening question, but I do know this. In fact, this is very particular weird knowledge that I know. The actual vials these come in are not they don't have any latex on them. They've made that choice specifically, and they're in fact in the emergency use authorizations that there is no latex on the actual vaccine vials that they draw from. So there wouldn't be any concern there, and there's not any latex product or anything like that in the vaccine itself. So.
Yeah. Amanda, we asked that question for all vaccines when we do influenza vaccination, for example. Any reason from your perspective that we use that as a specific screening question in vaccination?
Not that I'm aware of. And, the thing that I always think of when it comes to latex is gloves. And a lot of our gloves are latex free at this point. And I get this question a lot. You see some pictures of people getting vaccines and the person giving it is wearing gloves, and in some cases they're not giving it. It's actually not a requirement that you wear gloves whenever you're giving a vaccine. We're actually in the midst of the pandemic. We've gone through a various amount of supply shortages, and nationally, gloves are on that list. So we're actually promoting giving the vaccine without wearing gloves. But again, most of our gloves these days don't have latex in them. So I'm not exactly sure why we do ask that question.
All right, and Mary has a question about vaccination perhaps being rationing. She said, is vaccination ration according to hospital affiliation? I answered a Johnson County survey, and my friend answered later. I'm 10 years older, only the difference is my friend listed KU, I listed St. Luke's. This person is scheduled for a vaccination Saturday. Please explain. Do I need to change my answers to KU?
So the short answer is no. There is no determination specifically about where you get your care or how that means you would be called for vaccination, even in the Johnson County conversation that we've had this week. So first of all, we have been working very, very closely with both Johnson County and Wyandotte County, as our main campus is in Wyandotte County, but we have a number of facilities in Johnson County. So a number of hours of my own time this week, gosh, probably 5 yesterday alone, spent on this coordination with counties. And every hospital in Johnson County has agreed to be a vaccination site for their patients, really for any patients. That's a great thing, because that means there will be a lot of places that are able to deliver a vaccine as inventory rolls in and supply, hopefully supply shortages are not so much of an issue. Each hospital is able to choose how they contact patients or open their appointment scheduling. And so in our example, we did reach out to patients that we had contact information for. We had to do a randomization because we don't anticipate more than a couple thousand doses next week. But as we begin next week to think about how we vaccinate patients, and we're starting, of course, with those over 65, as we think about how we do that, we will be reaching out to people as we have doses available. So the first round of notes that went out saying we think we'll have an opportunity for you to schedule next week, or even maybe Saturday in some cases, was really based on those that we had easy ability to contact. But we do have a way, and we can get a graphic on this. I brought the specifics so I didn't mess it up. But on our website, there is a vaccine form. So at kansashealthsystem.com/COVID vaccine form, there is a web form that you can fill out if you're not an established patient. And by established patient, I mean having been seen here in the last 3 years for an appointment or at admission. If you're not an established patient, you can fill out a form there on the website, and that form, that will put you in a queue. So right now we'll only be pulling those who fill out that form who are over 65 when appointments and doses are available. But that's the way for those people who are not not our established patients, but are over 65, to signal to us right now that they would like to receive a dose here if they can. So again, we'll share that information more as the process progresses. This is sort of hot off the press. Really, as far as it goes yesterday evening, figuring out what it looks like. But there's no need to change your affiliation. The bottom line here is there are maybe 150,000 people in Johnson County alone who will be in phase 2. It's going to take us weeks, if not months, with all of the hospitals being vaccination sites and the county health department having vaccination clinics to get through those people. So that's sort of a plea for patience and a little bit of grace with us. We know that the demand for vaccine is high, and we continue to tell everyone to get it when you can, as soon as you can, and that is absolutely true. But we know we don't have enough supply to do that for everyone who wants it, who's over 65, even in our community tomorrow or next week. So hopefully that answers your question.
Yeah, we're having a technical issue. The guys just told me we need a new keyboard, and I said, buy it today. So we're sorry. Because I know that's like the most critical piece of information people want. We can't get it on the screen, but we'll have you say it again at the end of the update. Very last question goes to Isaac, and then we're going to wind up and do our goodbye. Isaac had a good question, and it's a good segue, and he wants to know, if enough people get the vaccine by mid-February, would it help us with maybe any post-Super Bowl celebrations?
Oh, I love the optimism in many
Yes.
ways. That's good. I think the likelihood that we get enough people vaccinated in February to feel good about a big celebration is low, very low. Not happening, kind of low. Dr. Fauci was talking about maybe the fall being a possibility for kind of return to some normalcy. And to me, a giant Super Bowl celebration is, sort of the definition of normalcy in terms of, big event, lots of people close together, that sort of thing. And that sort of thing's not going to really be possible until we have a really big chunk of the population vaccinated and immune. So that would be great, but I don't think that's probably on the horizon that we can get that many people vaccinated that quickly.
And
would agree.
our web team just told me that they have pinned at the top of the URL on the Facebook comments the information that people
There you go.
need. So,
Perfect. And we'll get graphics and information out. I said that ability to tell us that you'd like to receive a vaccine here, as I said, it won't make a difference for tomorrow or Monday. This is something that will play out over the next several weeks, probably several months. But absolutely would want to make sure that everyone has access to that information, and that's your way to signal to us you'd like to receive your vaccine here if and when you can. And of course, if you get an opportunity to get it somewhere else before then, won't be any problem. We'll just keep working through the list for those people who are ready and able. So, as we wrap up today, talking about next week, looking forward to Monday. Dr. Bahr is back, but in a different role. He'll join Kim Dixon, our Assistant Chief Nursing Officer for Ambulatory Services, who has been working tirelessly on all of our ambulatory treatment options, so monoclonal antibody infusion clinics being the prime example for outpatient treatments, but also vaccine clinics. So we owe Kim a debt of gratitude without a doubt. She and Dr. Bahr will spend time talking to us all about that. We'll also hear from one of our early patients. Paul Van Aram was lucky number 13 to receive bamlanivimab, our primary monoclonal antibody therapy, and his story is pretty remarkable. That's all on Monday. So as we wrap up today, Amanda, any final thoughts as we approach a Chiefs game?
Yeah, I think that was going to be my takeaway is we are all rooting for the Chiefs, and hopefully Patrick Mahomes can be back on the field. But we have to be very safe this weekend as we're celebrating. So maintain your distance, wear your mask, good hand hygiene. If you're feeling ill, don't go anywhere near other folks, and let's all keep each other safe.
Yeah.
Dr. Bahr.
I assume Dr. Stites is off today out of studio because he's practicing. He keeps talking about his
I think,
his replacement.
he was preparing just in case Patrick Mahomes isn't able to participate, that he might be called. I think the chances of that are low, but he's off catching a football or throwing one somewhere.
If you have, if you get that call, that email, that MyChart message that it's your turn for a vaccine, jump and say, okay, it's going to help us all. The sooner we all can get vaccinated. So I just encourage everybody. These vaccines are safe and they work, and please take your vaccine when you have the chance.
Yeah. I'll echo both of those comments, and also that I mentioned there is so much work from so many people going into vaccine distribution and planning and how we manage this. And we all know the importance of being able to get your dose individually, and the importance of that to the community from a population perspective. And we're working tirelessly to make sure that we're advocating for our patients and for our community, and that we never waste a single dose and that we're able to get vaccines in arms just as soon as possible. So know that is our focus as we continue, of course, to take care of patients who need to be here in our hospital for any reason, COVID or otherwise, and encourage you as we all get excited for a football game this weekend, encourage you and yours to do so safely in the ways that Amanda described. As we wrap up today, it is Red Friday, and everyone here at the health system is excited for our Chiefs. Some of our biggest fans are actually the smallest. So here are pictures of some recent newborns in our neonatal intensive care unit. Babies in our NICU often have complex medical challenges and are here with us for quite some time. Our entire team grows attached to these babies and their families, and they become very special to us. During any big event or holiday where normally a newborn would be at home and part of the celebration, we try to recognize that moment with these, our smallest patients, and make them part of our celebration in any way we can. They are a part of our health system family, and it's especially fun to celebrate these moments when going through a pandemic. And lastly, not saying we're superstitious or anything, but last year we presented our newborns with Chiefs gear to make being in the hospital during the playoffs, the AFC Championship, and the Super Bowl more exciting for families. So just in case, we kept that tradition alive. And finally, one of our more devoted fans is an employee who has had Chiefs season tickets for more than 30 years. He and his family had COVID-19 early in the pandemic and share how the Super Bowl high from last year helped them to get through the worst of their experience and how much they're looking forward to watching the big game this weekend as a family. We encourage each of you to watch as a family too. Stay in your bubble, stay safe, and remember, the pillars of infection control follow you wherever you go. Take care. We'll see you on Monday.
Maceo Jones is the Chiefs fan in all of us.
Everybody is talking about, hey, it's going to be another Super Bowl. And I say one game at a time, of course.
Maceo greets patients and visitors at the University of Kansas Health System.
I mean, help you.
But his side job, Chiefs superfan.
Well, you need a release valve. You're in a constant environment for the most part, be at home or wherever, just working back. So you have to expand yourself some sort of way.
A Chiefs season ticket holder since 1988, Maceo even enjoys a little pregame antics.
That gives you that opportunity to chide back and forth and to hear their little unkind remarks that we're not going to make it. And then when we come back on that following Monday, we can say, did you see what happened? So that livens things up in the day-to-day.
The high of the Chiefs' 2020 Super Bowl win in February helped carry Maceo through COVID-19 in April.
Me, myself, my wife, and my son, all three of us at the same time. I was the only one hospitalized for about 3 days. But to watch the football games now and see where we are today, that excitement then, and now that we have the vaccine, is beginning to say, hey, we got a new year.
COVID-19 recovered, Maceo looks forward to more home games with his daughter and another shot at the championship.
It garners a lot of hope and a lot of wishes. We're taking one game at a time. After a 50-year drought to do it 2 years in a row, this city is going to go bonkers.